Hi everybody, welcome. Today we have Ask the Doctor Live. My name is Dr. Srikant Duggirala. I'm one of the cardiac electrophysiologists here with Foothill Cardiology, and I'm working here at Emanate Health. Today we're going to have a discussion on what is atrial fibrillation. So that's what we're going to be the focus of our discussion today. I encourage you guys to send your questions to the chat box live, and towards the end of our conclusion of our discussion, we'll go over some of your questions, and hopefully we'll have some valuable learning experiences for all of us, okay? So let's get into our discussion. So first of all, I want to go over some general learning objectives. What is atrial fibrillation is, so understanding the definition is really important. Then we'll go over some of what the symptoms of atrial fibrillation are as well, too, as the patient's symptoms can be very variable. And then what is the risks of atrial fibrillation? What happens, as a consequence of living with atrial fibrillation and things like that? And then what other, how do we manage atrial fibrillation is just as important, too. Do we address the rhythm, the consequence of atrial fibrillation? So hopefully we go through each of these things individually to help kind of clarify each of these things. So first of all, why is atrial fibrillation so important? One is it actually is the most common irregular heart rhythm that we see in our community. In fact, it's thought that about 10% of our population at the age of 80 develop atrial fibrillation. It is not typically considered a life-threatening rhythm, but the biggest consequence of AFib is associated with the risk of stroke. In fact, it's thought that the risk of stroke is about 5 times per higher compared to the general population without atrial fibrillation. And as a consequence of that, there are some thoughts that it can increase the risk of developing dementia at an early age in some patients, particularly if their AFib is not well controlled or managed. Some patients are at risk for developing heart failure symptoms. And ultimately, like I said, it can be associated with risk of death overall because it can complicate other medical conditions. So that's why managing and understanding atrial fibrillation is an important thing for us. So what is the actual rhythm of atrial fibrillation? As mentioned, it is a common irregular heart rhythm. It's a rhythm of the upper chambers of the heart. And if you look at this diagram here below, often the normal conduction involves, activation from the upper chamber of the heart to the lower chamber of the heart. It goes from the sinus node to the AV node. And the electrical activation is what stimulates the heart to beat or squeeze and pump blood. And when you have atrial fibrillation, you have this more of a chaotic rhythm involving the upper chambers of the heart. So as a result, if you look at the EKG, the heart rate tends to be very erratic and irregular. That is a characteristic finding on an EKG or some sort of heart monitor for the patient or the physician that recognizes it. So now the definition of atrial fibrillation, just because we have atrial fibrillation is one thing, but really understanding the type of atrial fibrillation is really important too. Because that spectrum of atrial fibrillation is very variable. There are those patients that we often refer to as paroxysmal atrial fibrillation. And what that essentially means is those patients go in and out of atrial fibrillation, either on their own primarily, and then, or some sort of mechanism of action through where medications helps them convert back to normal rhythm. And eventually, those patients can become what I call more persistent form of atrial fibrillation. And that's where they kind of stay in atrial fibrillation more often than not, but only by some sort of method where a physician or a cardiologist restores back to normal rhythm. And that may include the use of certain medications, a procedure, and we'll get into some of those modalities and how we achieve those things. And there are also the term of understanding what is called long-standing persistent atrial fibrillation. And those are patients that have been in at least atrial fibrillation continuously for at least a year that we know of. And of course, there's also the termination or term that we call permanent atrial fibrillation. Permanent atrial fibrillation is often reserved as a term, to classify someone's atrial fibrillation when all methods of trying to restore normal rhythm either have failed or a patient chooses not to proceed with those modalities, in which case we just make sure, hey, the patient lives in atrial fibrillation, but we just control the heart rate and make sure the heart rate is adequately controlled. And finally, you may have also heard the term called non-valvular atrial fibrillation or non-valvular AFib. And that's due to understanding, hey, what else can cause atrial fibrillation? And that's when we do, when we look at the ultrasound images and we look at, is there any valvular disease that may predispose a patient to developing atrial fibrillation too? Because sometimes addressing that valve may also help that patient's atrial fibrillation as well too. And the reason this classification system is really important to help the physician understand, but also the patient understand, because it really helps kind of guide their therapy and understanding, how long a patient's have been in atrial fibrillation, and understanding the prognosis of atrial fibrillation is really important. The reason is AFib is kind of a chronic disease. It's not a one and done kind of thing. Patients, once they have AFib, it tends to come back. Episodes tend to last longer and tend to stay longer too. So understanding that kind of progression is really important for the patient physician to understand. What are the symptoms of atrial fibrillation? And on this list here, you can see the symptoms are very variable. Some patients are very debilitated by their symptoms of atrial fibrillation. Some patients have little to no symptoms of atrial fibrillation. And the vast majority are somewhere in between is what I typically have noticed in my experience. Those symptoms can include palpitations, like the patient is reporting, hey, my heart's beating fast or funny, often described as a fish flopping of their chest as can be the sensation of palpitations. Shortness of breath, where they just get tired a little bit more easily. They often, just can't do things that they're normally accustomed to doing. Some patients, their AFib is poorly controlled, their heart rate's going very fast and erratic, they can develop heart failure syndrome, so they can start to retain some fluid, and they can get symptoms associated with that. Some patients can also report chest discomfort or chest pain-like symptoms. Occasionally, they may describe some dizziness or lightheadedness as well, too. Sometimes the symptoms can be even more subtle, and as fatigue, where a patient, hey, I'm walking 5 miles a day, and all of a sudden I'm walking like 2.5 miles a day, I'm just getting winded more. Sometimes that could be a symptom of atrial fibrillation too. Of course, that has to be evaluated for other causes, but certainly AFib can present that way as well too. Okay. As kind of mentioned earlier, how is AFib diagnosed? There are different ways that we can diagnose atrial fibrillation. And this slide just really shows, again, what shows the normal activation of the electrical impulses of the heart. And when a patient develops atrial fibrillation, they have an irregular heart rhythm. It's often that chaotic rhythm involving the upper chambers of the heart. So really, it's diagnosed by someone listening to that heart. Hey, I'm hearing some irregular heartbeats. It may be suggested you may be having atrial fibrillation, like a physician or a care provider that's listening to the heart with a stethoscope. But more commonly, we're seeing these days patients being diagnosed with AFib through devices. That's either through the standard 12-lead EKG that's done through a doctor's office or a hospital setting. But more commonly, we're seeing a lot of mobile ways where people are picking up atrial fibrillation too. And you can see different diagrams here, different types of monitors. And these are continuously evolving. There's a lot of monitors on the market now. And just kind of quickly going through this first person here is wearing what we call like a patch monitor. So it's typically like a wearable patch monitor where a patient often receives this through their cardiologist or physician's office. They wear it for about 2 weeks. They often mail the monitor back, and the information is downloaded. And a physician reviews that, and they can see if there was anything like AFib or other irregular heart rhythms too. So these are not used exclusively for AFib, even though, like I said, AFib is the most common rhythm, but certainly other reasons as well to any heart rhythm-related disorders. Other monitors where a patient can be monitored through a live communication service that we utilize in some of our patients as well too. Sometimes we implant devices underneath the skin called loop recorders for patients who need to be monitored for longer periods of time. These devices can stay for 2 to 3 years in duration, depending on the type of the device and the manufacturer. Sometimes we just do a simple 24-hour Holter monitors, which have been around for a much longer period of time. But really, the newest technology is really the wearable ones. Patients can purchase these on their own, such as the Apple iWatch, for example, or a cardio monitor. These are FDA-approved devices that patients can purchase on their own. And, they are, FDA-approved at identifying irregular heart rhythms, such as atrial fibrillation as well, too. So sometimes when patients either pick this up on their own, it's always encouraged, hey, show it to your doctor to review that further. And then sometimes it may require some additional testing. But more importantly, it's really important to understand what are the risk factors of developing atrial fibrillation. The first thing I can mention, it is a irregular rhythm commonly associated with age. Certainly as we get older, age is a big risk factor. Certainly other things that can also contribute, people who have diabetes, for example, high blood pressure, particularly if it's not well controlled. Sometimes people have uncontrolled thyroid disease as well too. So checking their thyroid levels during routine lab tests can identify that as a potential cause for AFib. Obesity, really, really important. We know obesity causes a lot of medical issues in our patients too, but certainly directly impacts the burden of developing AFib. And we'll kind of go over that at the end in terms of talking about therapies as well too. People who have a history of heart failure for other causes too, they're more likely to be developing atrial fibrillation. These patients often have inefficient heart function, and that inefficiency can predispose them to developing more AFib in the future as well. Heart valve disease as well too. And surprisingly, genetics can play a role in some patients as well too, particularly in some young patients where they tend, where they don't have a lot of other risk factors, but all they're having is AFib. Sometimes genetics can play a little bit more predominant role as well too. The biggest risk of AFib is, like I said, it's not typically considered a life-threatening rhythm, although it can affect quality of life predominantly, but it is associated with the risk of stroke. So there's two modes of modality here. One is we'll talk about the treatment of AFib, the rhythm itself, but it's really just as equally important as talking about the consequence of AFib, which is really the risk of stroke. It's thought about 20% of people who develop strokes over their lifetime, it's thought that AFib could be an underlying cause of their atrial fibrillation. So often to reduce that risk of stroke, we often put people on blood thinners to lower that risk of stroke. And we'll go over some of those blood thinners shortly. But what kind of predisposes patients to risk of stroke? It's really your patient's risk factors. And if you can look here, we use, physicians typically use some kind of risk algorithm. It's called the CHADS-VAS system. And that's basically a conglomerate of various cardiac risk factors. People who have a history of heart failure, for example, high blood pressure, age as a certain cutoff, particularly if those are older patients above the age of 75 or 65 to 74, they get certain points essentially. Diabetes, a prior history of stroke, and it turns out females actually have a little bit of an increased risk as well too. So basically when we look through these risk profiles for each of these patients, we kind of calculate a score for these patients. And certainly the more points you have, it kind of puts you in a higher risk category of developing stroke related to AFib. So certainly the patients on this end of the scale, the guidelines do recommend being started on a blood thinner as long as a patient is agreeable to that and certainly don't have other risk factors that can predispose them to bleeding as well too. The low risk patients, certainly where their risk score is particularly low, it's often a discussion or maybe not even starting them on a blood thinner. And what is the mechanism of stroke related to AFib? So why does AFib cause stroke in some patients? So like I mentioned, the mechanism of the rhythm itself is a chaotic rhythm involving the upper chambers of the heart. So instead of the electrical activity causing the heart to squeeze normally, it's fibrillating. That's what the term comes from. When it's fibrillating, it's not squeezing in the upper chambers as well. And as a result, blood has a tendency to pool in that upper chamber of the heart, and sometimes clots can form. And those clots can break off and travel to the brain and cause a stroke in some patients. And certainly they can go to other organs and cause stroke-like effects in those organs as well, too. So that's typically thought to be the cause for a stroke in these patients. And as mentioned, how do we lower that risk of stroke? It's really blood thinners. That's the mainstay of therapy in trying to lower that risk of stroke. So typically, you can see on this slide, we have the conventional ones. Coumadin or warfarin has been used for decades, and it's still used in many of our patients still. But these days, we tend to kind of preferentially use some of the newer agents. Eliquis, Xarelto are probably the two most common one. Pradaxa actually was on the first of the market of the newer kind of blood thinners, but Savesa also is another one as well, too. The advantage of the newer blood thinners is they're certainly more convenient for our patients to take. You don't need to be monitored like warfarin or Coumadin needs to be done, where you have to go to a specialized clinic and to make sure your blood levels are within a therapeutic range. If you're too low with your Coumadin, then it's thought there's an increased risk of stroke. And certainly if your levels are too high, then there could be a risk of bleeding. So sometimes that needs to be monitored. But these newer ones don't typically need to be monitored as well. It's just often related to the patient has to reliably take their medications. Eliquis typically taken twice a day. Pradaxa taken twice a day. Xarelto and Savesa are once-a-day blood thinners, for example. And the choice of the blood thinner is really important, to discuss. There's typically not a big difference between these typical blood thinners, but sometimes either due to cost or, insurance coverage or certain other reasons, one may preferentially recommend one blood thinner over another. Now, the exceptions are someone may still need to take warfarin for if they have a mechanical heart valve or if they have significant valve disease, where warfarin is still the only preferred blood thinner in that situation. So that's, again, the discussion with your physician. But just as, being on a blood thinner is primarily there to reduce that risk of stroke, it's just as important to have that discussion about the risk of bleeding as well, too, right? It is a blood thinner after all. So we have to be cognizant with the patient, hey, some of our patients may be at higher risk for bleeding, especially ones that have had bleeding complications in the past for other reasons, particularly if they've, had GI bleeding, things like that. So it's always important to ask those kind of questions to the patients before starting a blood thinner. But sometimes we also have a separate kind of a risk algorithm that helps kind of guide us as well, too, as physicians to kind of use that. And again, certainly patients who are elderly may be at higher risk for bleeding. If they're taking other blood thinning agents such as aspirin or Plavix-like medications, say a patient may have a history of stents, for example, in their heart. So these additive medications may increase the risk of bleeding for the patient, and we have to kind of weigh those risk benefits if it's safe enough to add an additional blood thinner to do that. In some patients, blood thinners are not really appropriate at all, right? And despite, hey, this patient ideally should be on blood thinner because their stroke risk is particularly high, but this patient may be high risk for bleeding, or unfortunately has already suffered a bleeding consequence already, and they can no longer be considered a safe candidate. There is an alternative. We do these days something called a left atrial appendage occlusion device or a closure device. And this is one example. There's several on the market, but this is one of the more common ones called the Watchman device, for example. And this is often reserved for our patients who are thought to be high risk for bleeding or have already experienced bleeding complications, by being on a blood thinner, and it's thought that they're not a good candidate. So with this particular device, and it's a minimally invasive procedure where they put a mesh-like device in something called a left atrial appendage. The left atrial appendage is a remnant of the left atrium or the left upper chamber of the heart. And it's thought that when people have stroke related to AFib, it's thought that the majority of these clots tend to originate from the left atrial appendage. So this device was created to kind of essentially seal that off by creating this mesh-like device there. And it's some way to mitigate that risk of stroke. And patients still require some limited blood thinner for about 45 days after this procedure is done, but they can be safely taken off that blood thinner thereafter as well, too. Okay, so that kind of addresses kind of our blood thinning status and the stroke or management of atrial fibrillation. But what do we do about the rhythm itself, or AFib? Do we manage the rhythm and what the consequences of this rhythm? So it's kind of really broken down to two categories. One is called rhythm control strategy. The other is called rate control strategy. Rate control essentially implies that, hey, we're just kind of managing the rate of atrial fibrillation. The majority of patients, when they have atrial fibrillation, is due to when their heart rate is typically fast and erratic. And that being said, some people still feel their AFib or AFib-like symptoms, even if their heart rate's adequately controlled. And there are other strategies called rhythm control. Rhythm control implies, hey, the physician and the patient are motivated to try to get that patient back to normal rhythm, or sinus rhythm, as we like to say. And rhythm control may include different modalities. It may include something called AFib ablation procedure, something that I perform here in the hospital. Sometimes a cardioversion, essentially we shock the heart back into rhythm. Sometimes it may include the addition of antiarrhythmic medications that are specifically utilized for atrial fibrillation. And then, of course, rate control will go over some of those medications as well, too. Okay. And the main reason, again, with AFib, we're really trying to improve quality of life. We haven't really proven that we're going to necessarily make patients live longer. And that data is still kind of controversial and still being evaluated. But at this point, we're kind of expressing, hey, we want to try to preserve quality of life for our patients. Now, those patients with a history of heart failure or who have a really weakened heart, for example, trying to restore normal rhythm in those particular patients has been shown to show some mortality benefit in those patients. So we try to be a little bit more aggressive, particularly for those patients. Okay, so when it comes to rate control strategies of atrial fibrillation, what are the medications that we commonly use? So those medications include beta blocker medications or calcium channel blockers. Sometimes we use an old medication called digoxin, which is still kind of getting a revival again in terms of its use. These medications work differently but very similar. Their primary focus is to kind of slow down the heart rate related to atrial fibrillation. So our goal is we're trying to control the heart rate from being too fast and erratic. And say all options fail, the patient cannot tolerate these medications, or their heart rate is still very difficult to control despite high doses of medications. In some patients, the last resort option is actually we put a pacemaker in those patients, and we actually do something called an ablation where we actually disconnect the conduction system of the heart, but it does render the patient completely dependent on the pacemaker at that time. But that's kind of resort to last option is what I typically say. Yeah. And then rhythm control strategies, again, cardioversion, where we kind of shock the heart back into rhythm. That's an option to discuss as well, too, with your physician. And then rhythm medications as well, too. There are certain class of medications that we use for our patients. Again, the selection of these medications is really dependent on the physician, the patient's risk factors, and the physician discussing that with the patient. And then finally, I want to go over catheter ablation. Basically, this is a procedure where we actually go into the left upper chamber. It's a minimally invasive procedure where we actually kind of cauterize inside the upper chamber of the heart to kind of isolate the triggers of atrial fibrillation. It was discovered about 20-some years ago the common triggers for AFib come from inside something called the pulmonary veins, and they bring the oxygenated blood back to the heart. So we take a catheter, essentially burning around the outside of the veins to kind of isolate the triggers, essentially creating a scar on purpose. But the goal is we can control AFib more effectively that way as well. And this is just showing a 3D rendering of those maps that we utilize during the creation of those chambers and those ablation. And this is just showing one example of that. And this is another way to accomplish the same thing. This is actually using something called a cryoballoon technology. Essentially, heating or burning the tissue. You can actually freeze the tissue as well, too. So some centers that do ablation may preferentially use this. There's no real difference between ablation with either radiofrequency or cryoablation, but there are just those options available. And the success rate is really dependent on how much atrial fibrillation a patient may be having. So as mentioned, the diagnosis and understanding those definitions is really important. So those patients with what we call paroxysmal, where they're going in and out of atrial fibrillation, actually the success rates tend to be a little bit higher because their AFib hasn't affected that upper chamber of the heart as much over time. So those success rates after about one ablation is about 75% having little to no AFib thereafter. And those patients with more AFib or more persistent forms of AFib, the success rate is about 50 to 60%. But some of those patients may require multiple ablation procedures to even achieve those goals as well, too. And as I mentioned, there is no magic cure for atrial fibrillation, whether it's ablation, rhythm medications, cardioversions. It's a combination of all these things that's going to help control atrial fibrillation. And of course, no thing is more important than risk factor modification for our patients. And so that includes, weight loss is really critically important for our patients, encouraging weight loss, limiting alcohol intake. Alcohol can be a big trigger for atrial fibrillation, sometimes and certainly in excess, but sometimes even more modest intake of alcohol can cause AFib as well, too. Sleep apnea, which is very underdiagnosed in our community, and certainly, talking to family members about snoring symptoms, daytime fatigue can be early signs of sleep apnea. Certainly going through the evaluation and getting tested for sleep apnea and treating sleep apnea can help AFib as well, too. So finally, in summary, AFib is the most common irregular heart rhythm that we see. It has a variable degree of symptoms that can vary. Some people have very minimal symptoms. Some people have very severe symptoms. It is a significant cause of stroke, so having that discussion with your physician, whether a blood thinner is appropriate for you based upon your risk profile. There are different strategies that we use to control atrial fibrillation, whether it's a rate control or rhythm control strategy that we can utilize, and again, to discuss with your physician about these modalities. And of course, the most important thing, risk factor modification. If anything I want you to take away from these talk, risk factors goes a long ways. Weight loss, limiting alcohol intake, evaluation for sleep apnea, controlling diabetes, hypertension, all these things are really important for the long-term success. Okay? So thank you very much for joining us. Hopefully that was insightful for you. We do want to encourage you to send some questions now that we'll go over. Okay? And so we'll go over those questions now shortly, okay? All right. So first question I have a heart ablation. Is a blood thinner still needed? Good question. So after an ablation procedure, we usually don't use ablation to get people off blood thinners. It's not an indication. But that being said, if your risk of stroke is particularly low, where your CHA2DS2-VASc is really low, then we can particularly have that discussion with the patients. Usually my approach is I tend to have a monitoring period for my patients where they come back after an ablation procedure, and if the risk of stroke is particularly low and they're not having any significant AFib at all, I think it's reasonable in some of those patients. But particularly those patients who are higher risk for stroke, I tend to encourage them to stay on the blood thinner for that reason. Okay. And the next question I have, can hormones affect AFib? and can cause irregular heartbeats. Certainly, yes. I have seen it, particularly, some, hormonal imbalance. We talked about thyroid, for example, can do it as well, too. If your thyroid is hyperfunctioning or hyperthyroidism, that can cause people to develop atrial fibrillation. Other hormonal imbalances, particularly women going through either perimenopausal symptoms, I have seen it. Not as strongly associated with atrial fibrillation in my clinical experience, but I have seen them develop other irregular heartbeats or irregular extra beats sometimes. But usually these things can tend to be a little bit more benign and tend to subside over time. But I don't know there's a strong correlation of AFib and particularly perimenopausal women, for example. We did talk, the next question was, does hyperthyroid cause issues? Yes. Relate to electrophysiology? Yes. Hyperthyroidism can cause atrial fibrillation. Hyperthyroidism, for example, not only can it cause atrial fibrillation, even if it doesn't cause atrial fibrillation, patients just can have a racing heart rate related to that, and they just may be in normal rhythm, but they may have the symptoms of that as well, too. But definitely a cause for atrial fibrillation. And sometimes treating that thyroid and getting it under control will sometimes help resolve that atrial fibrillation or certainly make it easier to manage as well, too. The tough question here, does AFib shorten life expectancy? Now, I did mention that AFib does not necessarily increase mortality, but in a way it can complicate other medical issues for our patients, too. It does, I mentioned, there's some observational data where patients can have increased risk of dementia, for example. The main thing with AFib management is primarily quality of life. But that being said, I have plenty of patients that live in atrial fibrillation well into their 80s, and they're doing just fine as well, too. So it's really what I've noticed is really a quality of life, but when those other patients have other significant comorbid conditions, high blood pressure that's not well controlled, diabetes, so those things will compound and make it more difficult to manage the overall picture, and those may more directly impact the life expectancy of the patient over time. Next, yes, good question. Next is AFib is controlled through heart ablation, does it lower the risk of stroke and dementia? Yeah, certainly you would think that if you're not having any atrial fibrillation, are we modifying your risk of stroke? Certainly if you're not having AFib, it's thought that theoretically your risk of stroke is going to not be as high as someone who's having more atrial fibrillation. And certainly, the mechanism of dementia, we're still trying to understand that, but it's thought that people can be either due to having micro strokes that may accumulate over time that can lead to developing dementia over time, or they're having small hemorrhages that are causing that either due to being on blood thinners. We don't fully understand that, but these are due to micro things. Studies are still ongoing about that, but yes, maintaining sinus rhythm will potentially suggest that as well, too. And can stress cause atrial fibrillation? Yes, I have seen that. The nervous system is a very powerful thing to the heart. When the body's under a lot of stress or the patient's feeling a lot of stress, we know that the nervous system also affects the heart, something called the vagus nerve, an example of that too. And the vagus nerve is a large nerve that comes from the brainstem and stimulates the heart and the gut, for example. And we have seen it particularly that the vagus nerve and the nervous system and its role can influence and trigger AFib in some patients. And I have seen it clinically where patients with a high level of stress are more likely to develop atrial fibrillation in my clinical experience. And then what is the recovery after an AFib ablation procedure? So typically these patients, the procedure takes a couple of hours to do. It's done under general anesthesia. Patients are on bed rest for about 6 hours. I tend to keep my patients overnight in the hospital just for monitoring purposes, and patients typically go home the following day or the following morning. I tell them to take it easy for about a week afterward, just to kind of let the groins kind of heal up, because all we're doing is just accessing the veins in both groins, and it, just have the light activities. Patients can go for walks the next day. I tend to tell them not to do any heavy lifting or rigorous activities for about a week or so, but the recovery time is generally pretty quick for most patients, and they can resume most of their activities within a week or so afterwards. Next question, do you recommend cardiac rehab for patients who have undergone a heart procedure? So for typically, most of my patients, I tend to encourage cardiac rehabilitation services. I think is a really good, particularly after they've had open heart surgery or recuperating from heart failure symptoms. I don't typically recommend cardiac rehab for AFib primarily. Most of my patients are generally pretty active and pretty mobile for the most part. But certainly if you have other conditions, they're recuperating for open heart surgery, from bypass surgery, valvular heart surgery, or they've had a history of heart failure symptoms, and they need to do a little bit more physical conditioning, I think cardiac rehab is a great resource that our hospital actually has, and a lot of our patients utilize it. And every patient I know has loved their cardiac rehab experience. And I think they get great feedback, and they get, really builds a lot of self-confidence, and they really develop great stamina through that experience. I think those are the only questions I've received so far. Okay. So again, I want to thank you all for joining us today. Hopefully you guys learned a little bit about atrial fibrillation, the diagnosis of atrial fibrillation. Certainly, I'm happy to ask any questions that come through me, through the hospital. And finally, we also want to encourage you to seek, not to delay your care at part of Emanate Health. Our services are full go here. We're doing all our cardiac procedures. I know surgeries are busy. We want you to encourage you to follow up with your physicians and make sure we're there to provide the care that you need. Thank you.